You know that moment, right? That sudden, unsettling feeling that your knee just didn't track quite right.
Yeah.
Maybe it felt like it shifted out of place or even gave way completely for a second. It's actually pretty common, especially if you're active.
It really is. And that sensation, that instability, it often points directly to how the kneecap is interacting with the thigh bone.
Exactly. And today we're taking a deep dive into your material, your notes,
Right.
specifically on patellar subluxation. We're talking about that partial, sort of temporary slip of the kneecap.
And our mission, really, is to cut through the detail in your sources, pull out the most important bits, give you a high-yield understanding.
Yeah, what it is, why it happened.
How you spot it, how it's managed, all drawn straight from the info you've shared.
Okay, let's get into it then. First off, what is patellar subluxation at its core? Your notes give us a pretty clear definition.
So basically, it's a partial or incomplete dislocation of the patella, that's
Mhm.
your kneecap, from the groove it normally sits in.
The trochlear groove, right.
That's the one on the end of your thigh bone. Think of it like maybe a train wheel just momentarily slipping off the track a bit.
But not coming off entirely.
Exactly. Not a full derailment, just a slip.
Ah,
Oh,
okay. The partial slip. Makes sense. But why does that happen? What causes it? And what makes someone more likely to get it?
the notes list quite a few factors.
Yeah, and what the material really highlights is that it's rarely just one single thing.
Yeah.
It's often multifactorial. So causes can include things like anatomical variations, how your bones are actually shaped,
Right.
muscle imbalances around the knee and hip are a big one, general looseness in the ligaments, and sometimes, yeah, it's triggered by a specific twist or a knock.
So certain body types or maybe previous issues can kind of set the stage for it.
Absolutely. The notes point out some key risk factors. It's seen more often in females.
Okay.
Having a history of it before previous patellar instability, that's a big predictor. If it's happened once.
It's more likely again. Yeah. General ligamentous laxity, what some people call being double jointed, that increases risk too.
Right.
Muscle weakness, particularly in the quads and hip muscles, that plays a role. And then critically, anatomical things like a shallow trochlear groove, if the track isn't deep enough,
Less stable.
less stable, or how high the kneecap naturally sits. These structural issues just provide less sort of bony stability.
Okay, so how do all those underlying factors actually translate into the kneecap slipping? What's the mechanism, the pathophysiology?
It really comes down to how the patella tracks how it moves within that groove when you bend and straighten your knee.
Okay.
When you've got those anatomical issues or the muscle imbalances or the loose ligaments, the patella's movement just isn't smooth. It becomes abnormal.
Right, it's not gliding properly.
Exactly. And this abnormal tracking creates instability, making it prone to sliding partially out of the groove. That's your subluxation event.
Got it. Mechanics explained. Now, how does someone experiencing this actually feel it? Or how might we, see it? What are the clinical features, the symptoms and signs?
So symptoms typically include pretty acute pain right in the knee.
Hmm.
People often describe that very distinct sensation of the knee giving way or buckling.
Like, just won't hold you.
Yeah, or feeling like something is shifting inside. You might also hear or feel an audible, like popping or snapping sound when it happens.
Ooh.
And swelling around the knee is a very common thing afterwards.
And physically, what might be obvious if you're examining someone?
Well, the signs can include that swelling we mentioned.
Hmm.
And if you're actually there when the episode happens, you might literally hear that pop or snap.
Wow.
In some cases, during the episode itself, the kneecap might even look visibly shifted or displaced before it pops back in on its own.
Okay, so if someone comes in with knee pain, instability, what else could it be? The notes mention differential diagnoses.
Yeah, this is a really important point for anyone looking at knee problems. While patellar subluxation is definitely high on the list,
You need to think broader.
exactly, your sources remind us to consider other things, like a full patellar dislocation where it comes completely out and stays out.
Right.
Injuries to the big ligaments inside the knee, like the ACL or PCL, those are major stabilizers.
Okay.
Meniscal injuries, damage to those cartilage shock absorbers, and osteochondral defects, which is damage to both the cartilage and the bone underneath. Got to rule those out.
Makes sense. And who typically gets this? Is there a sort of usual demographic?
The overall prevalence isn't perfectly known, but the material suggests it's relatively common.
Okay.
It most often affects adolescents and young adults,
Right.
particularly those active in sports, things involving twisting, jumping, sudden changes of direction.
Right, those high demand movements. So how do we actually confirm the diagnosis and figure out the specifics? What investigations are typically used?
Diagnosis really starts with a good clinical evaluation. Listen carefully to the person's story, the history of what happened, and doing a thorough physical exam. Checking stability, alignment, that sort of thing.
And then imaging.
Then imaging, yeah. It's key for understanding the underlying structure and any associated damage. X-rays are often the first step. They look at bony alignment, the shape of that trochlear groove.
Okay.
MRI or CT scans give you much more detail on the soft tissues, ligaments, cartilage, and a clearer picture of more complex bony things like how deep the groove actually is.
Right, gets you the full picture. So once it's diagnosed, how is patellar subluxation usually managed?
Management is typically conservative initially. The core things listed are rest, maybe some temporary mobilization with a brace, just to let things calm down.
Then it's settle.
Yeah. And crucially, physical therapy. PT is huge here.
What's the focus?
Really focusing on strengthening the muscles around the hip and knee, especially the inner part of the quad muscle, the VMO, to improve how the patella tracks and its stability.
Makes sense.
Bracing or taping can also be used for support during activity, give a bit more confidence. Surgery is usually held back for severe cases or if the conservative stuff doesn't work and it keeps happening.
Okay. Looking ahead then, what's the typical outcome with proper care? And I guess what are the risks if it's not dealt with properly?
With good management, the prognosis is generally pretty positive.
That's good.
Yeah, it often leads to really significant symptom relief, better knee stability, and lets people get back to their normal activities, their sports.
Yeah.
The, the notes are clear about potential complications if it's untreated or managed poorly.
Like what?
Things like persistent recurrent instability, meaning it just keeps subluxating. Chronic pain becomes an issue. You can get progressive damage to the joint cartilage over time.
Uh-oh.
And that increases the risk of developing osteoarthritis in that knee down the line. So, yeah, it's not something you want to just ignore.
That really underlines why getting the right management is key. Okay, so we've walked through the definition, the causes, how it presents, diagnosis, management, all based on your notes.
I think the big picture takeaway, really, from this material is that multifactorial nature we talked about right at the start.
Right, it's not just one thing.
Exactly. Because several different factors can feed into this condition for any one person. Success in the long term really depends on identifying your specific underlying issues. Is it muscle weakness? Is it bone shape? Ligament laxity?
You have to tailor the treatment.
Precisely. Tailoring the management plan to address those unique factors is key. It's definitely not a one-size-fits-all kind of fix.
A really crucial point to remember. And for more high-yield deep dives like this one to help power your revision, definitely check out pastthemsra.com and freemsra.com.